Hello, everyone. Thank you for joining another interview of Journal of Immunotherapy and Precision Oncology. I am Dr. Shambhavi Singh, the Editorial Fellow of the journal, and we have here with us Dr. Mehmet Asim Bilen, Associate Professor from the Department of Medical Oncology and Hematology, Cancer Institute of Emory University, Atlanta. And we are here to discuss on the combination immune checkpoint blockade regimes in the untreated metastatic renal cell carcinoma.
Thank you so much for having me and also able to discuss our work, Dr. Singh. Thank you.
Yes. Dr. Bilen, thank you for joining with us today. And we would just move on to our first question. That's regarding the recently published data of the real-world data on the treatment of the metastatic renal cell carcinoma. We would love to hear an overview of your study.
This study was led by one of our stellar Emory medical student who is internal medicine resident at MGH right now, Dr. Martini. First of all, I want to highlight him. He's a fantastic researcher, and I think in the future he's going to be a perfect addition to our research effort. I just want to highlight him and his effort, and I will be glad to be one of his mentors for this publication. And as you said earlier, we reported the real world outcome of patients with advanced kidney cancer who were treated with combination immune checkpoint inhibitor in our institution. This is an evolving space. Because of this reason, we also want to publish our own experience on series for the scientific community.
We would like to know a little bit regarding the subset of the patients in your study and how is it similar or different as compared to the other metastatic renal cancer study?
An excellent question, Dr. Singh. As we all know, the frontline therapy options are changing in metastatic RCC. We have multiple new drugs, multiple new combinations, but unfortunately, we don't have any validated biomarker that we can use in clinic to help us which patient should receive what treatment. I think this is an overall problem in our clinic. And we definitely need a validated marker, like a biomarker in our clinic. In this cohort of patient, it's mainly clear cell histology, which is the common form of kidney cancer that we see. And we know that patients with sarcomatoid subtype tend to have better response to immunotherapy-based treatment, especially combination of IO regimen like Nivo-Ipi. And in our analysis, we also see the similar trend. Patients with sarcomatoid histology had a response rate of 44%, which is higher than the overall population. But again, we still need a good biomarker that can help patient selection and potentially increase response rate and also avoid unnecessary toxicity. And this is overall what we still require in our clinic. And overall, as a field, we are all working on it based on clinical, like a biomarker or biological biomarker. And hopefully down the road, we have something that we can use in our patients.
That's amazing, and that's very insightful. Can you mention the key results and the toxicity data?
This is relatively a small cohort of patients since it's coming from single institution. We have total of 49 patients in this analysis, and median age was 65 and predominantly male, which we see overall in kidney cancer. It tends to see more male than female. And in our cohort, most of the patient received combination nivolumab and ipilimumab, which is a PD-1 CTLA-4 combination. And that is the first combination got FDA approval. Because of this reason, why we have more patients receive Nivo-Ipi. Rest receive other combinations, including IO-VEGF TKI, such as pembrolizumab and axitinib. Based on our analysis, the median OS was not reached. The median PFS was 8 months per Kaplan-Meier estimation. The objective response rate was around 33% for the entire cohort. And we have 7% had a complete response. One of the challenges for immunotherapy-based combinations are immune-related adverse event, or what we call IRAE. And we see close to 50% of the patient experience an IRAE, and roughly 27% need to stop or delay a treatment, and then eventually 18% need to stop due to toxicity. And this is another area that we further understand who's gonna had one of those side effects, and then if they have side effects, what kind of treatment can apply. But this is very similar also what was published in the literature. Again, we presented the real-world efficacy and toxicity data for frontline immunotherapy combination. We see objective response rate and median PFS were lower in our cohort when we compare with the clinical trial data. But this is not a surprising finding because we know that patients enroll in the real-world data are different than clinical trial population. They have more advanced disease. They may have more significant clinical issues than clinical trial population. Because of this reason, this is not a surprising finding. But we still need future studies that provide additional data that allow us comparing different combinations and also learn how those combinations behave in the real world setting.
What would be your thoughts on the novel immunotherapy combination regimes in the clinical trial setting that shows a great promise in the first-line setting for the metastatic renal cell carcinoma?
Dr. Singh, yeah, I think as a GU medical oncologist and kidney cancer expert, I think overall the space is very dynamic and very promising options are becoming available for our patient. Because of this reason, we are all very excited, what we saw past several years, and we are also very excited what we're gonna see in next couple of years. First of all, Nivo-IP combination got FDA approval, which is the only IO-IO combination. And then last 5 years or so, several IO-VEGF TKI combinations got FDA approval, including pembrolizumab plus axitinib, avelumab plus axitinib, nivolumab plus cabozantinib, and pembrolizumab plus lenvatinib. Now we have multiple very effective, very strong therapy options for our patient, and this is why we are so happy, overall. And most recently, this year, we also start learning the triplet combinations. We know the 2 is better than 1, and this is why all those doublets got FDA approval. But now we start asking the question, what about triplet? For example, this year at ESMO, a Cosmic 313 trial was presented, which is the first triplet trial in the front line. And this clinical trial comparing nivolumab plus ipilimumab plus cabozantinib versus nivolumab plus ipilimumab. Again, this is the first triplet combination. The study met the primary endpoint, which is a PFS improvement, but we are still following this trial for other data, including OS, toxicity, and we're gonna figure out how we're gonna adapt this kind of triplet combinations in our clinical practice, because clinical outcome, response rate, PFS, OS is one thing, tolerability and toxicity is another thing, and we need to sort of able to handle for both and make an effective drug, but also a tolerable drug for our patient. But this is not the only triplet trial. There is a number of other triplet trials are currently enrolling. I think overall the field is moving in the right direction, and then hopefully we're going to bring more and more treatment options for our patients in the near future. And hopefully one day we will cure metastatic RCC, which is all of our dreams, and hopefully we can achieve this in the near future.
Yes. So on to the last question, that how would you could briefly discuss the strengths and the limits of the study, and how would you suggest results being applied to the clinical patients?
All using randomized clinical trial to change our practice, because this is what we have to do. We need to have randomized phase 3 trial, compare a current standard versus the new experimental drug, and we need to show there is an improvement before we adapt or change our practice. But I think real world data is also very important to supplement the prospective clinical trial, just to further validate the activity of treatment and also toxicity in patients that might not be eligible for the clinical trial, because we know that not everybody can be eligible for clinical trial based on comorbidities and organ function and other things. Because of this, we still need to treat those patients. And I think learning from those patients are going to be very important in our field. In addition to that, some of the rare histology that might not be represented in clinical trial, I think real world data is also very important, just to widening the experience and knowledge. I think real world data also play a role. And we try to do that in our study. And of course, the real world data also have some limitations, and we listed that in our publication. First of all, it's retrospective, which can limit our data collection, such as we couldn't grade all the adverse event, because those kind of things not always readily available in our clinical note. This is a small cohort, because of this reason we couldn't have a big population receive IO-TKI. We only have 6 patients, for example, receive pembro-axitinib combination, just because those combinations got FDA approval later. Because of this reason, I think additional data is important. Additional data are important for head-to-head comparison for those combinations, IO-IO or IO-TKI. And then overall, I think as a field, we start using more and more real-world data to improve our understanding and knowledge for our patient.
Okay. Thank you so much for the insightful discussion, Dr. Bilen. And we look forward to more studies in the clinical setting, such as these. And thank you so much for taking your time out for the interview with Journal of Immunotherapy and Precision Oncology. Thank you.
Thank you so much, Dr. Singh, for having me. And thank you so much for doing very excellent work at JIPO. And glad to be part of the journey. Thank you.